You look unwell.
I think
Hey,
it's the
everyone.
lighting. Good evening, everybody. Thank you for waiting. We just had to sort out some video issues here. Uh, we are here with Dr. Alex Khominsky. My name is Dr. James Trad. We are both from General Dental Residency, and we are here presenting part 2 of our free webinar series. And tonight's topic is minimally invasive extractions. Dr. Alex Khominsky is a specialist periodontist in Melbourne, and he enjoys all aspects of perio, implants, extractions, and of course, debridement. But here he's talking about a very fun subject that he enjoys discussing. Uh, I think it's a very important subject as well. If you are doing routine extractions, not just wisdom teeth, especially if you want to get into the world of implants. So I'll get straight into it, and I'll leave it with you, Alex.
Hey, everyone. Lovely to meet you all. Really looking forward to this presentation. I did this presentation or a similar one a couple of years ago. And as James said, this involves everyone who, whether you're a new grad and recent grad and trying to approach extractions in a predictable way and you want to get into more complex surgical and wisdom tooth extractions, a lot of these techniques will apply to that as well. And secondly, for those who are already getting a bit more confident, creating a bit of a mind map in terms of a workflow in terms of extractions. Now, if I don't see your questions through the chat, please post the questions there. I'll make sure that at the end we can run through everyone's questions. And if something pops up, just shoot the question. I'm sure others have the same kind of a similar question as yourself. So looking forward to going through this with everyone. So for those who don't know me, I'm sure some already do. My name is Alex. I was born in Ukraine, but grew up in Melbourne and was very fortunate to grow up here. I did my dentistry in Adelaide University, did that for 5 years, came back to Melbourne. I worked at the Alfred Hospital, had a really, I'll say, privileged experience there where that was 1 year where I worked essentially in a dental unit in a hospital team, helping patients with organ transplants, severe immunosuppression, going through cancer treatment, and under anticoagulants, hemophiliacs, and so was also had the support of a lot of specialists, which was really a formative part of. And then went on to private practice, went on to perio later on at Melbourne University, and also last 5 years been also part of GDR. And very fortunate to have James, who's recovering from a procedure himself, being with us for almost that time period as well, and essentially helping new grads, recent grads, and now also with our advanced diplomas, more experienced clinicians, essentially make the most out of dentistry and do more of what they love. So today we're going to cover a few things. We're going to run through initially some of the fundamentals: surgical setup, informed consent, case selection, risk assessment. Then we're going to start warming our way up into clinical, how to provide local anesthesia, some tips and tricks for anxious patients. And then really for those right now who maybe approach extractions in the sense of, look, I'm going to put a luxator, I'm going to try and get movement. Once I get movement, I'm going to apply my forceps. And hopefully once I apply my forceps, we can get enough movement to get the tooth out. The mechanics and anatomy part of this is about really changing that mindset and thinking of extractions no different to how you think about your crown preps and your restorative. Thinking about every little step in terms of, do we cusp cap, do we not cusp cap? How am I bonding? Where am I doing this? What's my isolation? And obviously those exact things don't apply to extractions, but we need to have more than just luxate or elevator, wiggle, and then forceps. And so putting a little bit of kind of intuition and giving you a plan so that tomorrow or this week, when you have your next extraction, you have an appropriate assessment. And then based on assessment, you can actually have a plan of how am I going to go through each step so I can deliver this tooth as predictably, as quickly, and as least stressful as possible. We're going to go into minimally invasive techniques. going to work our way up into more kind of complex surgical extractions and then into complications. And in terms of surgical extractions and what's a surgical, what's a sectional, obviously there's item codes. But in my kind of experience and practice, outside of third molars, almost every other tooth can be extracted in a flapless approach. And that comes down to your quality of sectioning, quality of tooth and bone removal, being selective with the bone removal. And not to say there's anything wrong raising a flap, doing a buckle gutter sectioning. Perhaps that's one way that you start. But over time, as you get better at having good visualization, good sectioning technique, the right instruments, you actually will find that raising a flap for the purpose of removing the tooth is often not necessary. So that's my goal for you, to have all of you kind of seeing that going forward. So with the setup, I think one of the important things with setup and where I see in our grads who've gone through the core residency, there's over 250, 300 of them at this point, is in your assessment. Now, for example, when I'm extracting a molar, I will always have a handpiece set up. I'll always have my burrs set up. I'll always have a combination of some instruments in what's a basic setup. And then we also know that, things getting more complex, we might need other instruments, we may kind of advance that setup. And so I think the number one thing that I would take away in terms of setup is starting tomorrow, whatever case you feel. Now there could, I say molars at the moment, but if I assess a case and let's say there's a complex canine, I'll also have my handpiece set up, because canines in particular, they can catch us off guard. We think single root tooth's going to come out easy, but they can be very long roots. The bone can be fairly dense, especially on the palatal. The buccal can also fracture, and you have this oblong shape. So having your nurses ready, because where it gets stressful, you start luxating, you start using forceps, and then 10, 15, 20 minutes in, you say, look, I think I need a handpiece of my burrs. So your nurse has to deglove, go set up. So being more proactive with your setup. Now, a surgical setup can vary quite a lot. Now, we can go into contra angle versus straight handpiece, and there's benefits in both. Personally, I do use the contra angle most of the time. However, I am not doing on a routine basis third molar extractions. If you are, and you do need deeper access, a straight handpiece can also be very useful in that regard. But having your topical, having your local anesthetic, where you can see and you've assessed that the patient may need surgical extraction, considering having sutures, scissors, everything kind of ready to go, so that once you kind of knife to skin, there's no need to be calling or changing setup. The other thing I want to go into is luxators. Now, get to know the luxators in your practice. Often I'm using a 3mm luxator. Rarely am I using 5mm luxators, just due to their width and kind of destruction of the bone. So often in my practice, again, being minimally invasive, I'm using 2 to 3mm luxators. And that just gives me more control of where the luxator goes, more ability to go deeper. Nothing wrong with 5mm luxators if that's what you're using. But as you start sectioning teeth and kind of turning a multi-rooted tooth into multiple single-rooted teeth, you realize that the 5mm luxator is enough. But having also some luxators with a curve, but also checking the edge of your luxator, make sure it's sharp, make sure it's, if they've been used for a long time, their edge has been dulled, look at being replaced. Forceps, again, just have good forceps. When you start sectioning teeth and turning things into single root teeth, essentially you're using less molar forceps, but also just make sure in your universal or kind of finer forcep range that you've got something that has a nice fine grip. Handpieces, this is my personal kind of setup in terms of burrs and handpiece. So welcome to use this if you don't have, but having a surgical handpiece that you could plug in saline if you need to. In terms of burrs, this is my kind of go-to. I've got a long carbide. In terms of length of this burr, I think it's about 35 to 40 mils. So it does allow me to have very delicate access where roots have fractured, or I need to be able to visualize kind of further deeper within sockets. For kind of bulk tooth sectioning decoronation, I do like these friction grip burrs on the far right there. Very fast, very efficient. But like with anything, with burrs, replace them. If I was doing a set of 4 wisdom teeth, after that set, maybe a couple more wisdom teeth, I'm throwing out these burrs and replacing. If you're having to put a lot of pressure, again, that just puts an increased risk that you might slip, that you might burn the tooth. If you're starting to have to put a lot of pressure with working your burrs, replace them. Having some basic things like Minnesota's, tongue retractors, bite blocks, especially with patients, and the more posterior you go, needing access sometimes, and every patient's a little bit different, but for a lot of patients, actually having a bite block to rest on actually can be more comfortable. Suturing, whatever your fancy is, obviously, as a perio, I'm just used to using Castros, so that's my go-to wherever in the mouth. Suturing, tissue forceps, again, tweezers, or whatever kind of works for you. Having cheek retractors, having scissors, having things set up. Sutures in extractions, I'm not going to kind of dive into the suture world too much unless you've got any questions. My go-to for an extraction socket is probably a fluorochromic. It's a monofilament. There's less plaque trapping and biofilm accumulation around it. You tend to have resorption within 7 to 10 days. But if for some reason you want a flap to be secure for longer, have a longer resorbing suture, something like a polyglycolic, such as glycolon or monofast, they can retain their tension for up to 2 weeks to 30 to 50%. So again, thinking of like a monofilament suture, one of the main benefits of this over a multifilament is just less plaque induced in the area, less inflammation. However, in terms of something like a vicryl, there are certain situations where you may want a vicryl. And certain vicryl sutures that are treated, there's kind of newer versions, they are a little bit less plaque retentive. In terms of needles, again, typically we're looking at a 3/8, and we'll go into why. So typically in our oral surgery, a 3/8 just allows you to get a nice equidistant grip and bite from buccal to lingual or lingual to buccal. Scalpels. If you don't, I really recommend having rounded scalpel blades. Just allows you that better access. Typically, I'll have just mainly 15C blades and 12D blades. There are scalpel handles with curves for difficult to access areas, but obviously you got your classic flat as well. There's nothing wrong with that. Elevators, cries, curettes. Again, if you're raising a flat, obviously a mold elevator of some sort would be beneficial. Cries, again, not usually I would typically have out straight away. However, if I am doing some sort of third molar removal, I will have these out usually routinely, because once we start, we want to be able to access things quickly, because that's where stress, fatigue, and also delays can really impact root picks or more difficult. But having curettes is really important, especially you're extracting teeth with granulated sockets. Sometimes in these cases, extracting tooth is very easy, right? You pop the tooth out, there's so much granulation tissue, but actually degranulating around the bone to allow fresh bone margins, so you have a fresh socket for better healing. Otherwise, sometimes, and this is important again, if you're wanting to work your way up into socket grafting or implants, this is a critical process, because essentially by leaving granulation on the bone, you have a couple of options. One is a cyst may form. 2, you may not have bone healing as soft tissue granulates into that area. So you have essentially not ideal healing in that area. Or 3, again, you may have a high risk of infection or something of that nature. Irrigation is also important. So in terms of a basic setup, I put here is like a very kind of basic situation that you may want to have and start having for most of your extractions, or extractions that you deem, okay, this is going to need a little bit more. So having your luxators, having your forceps, handpieces, the Minnesota, and bite blocks. On the kind of second front, you may want to look at something like multi-elevator scalpel. If you're going to need to raise the flap, you're going to need those. And then looking at the patient, if you're suturing, needle holders, tweezers, gauze, surgical suction. But I think the big takeaway is handpiece and burrs definitely be a bit more proactive here. So this is what it looks like. Basic is quite basic. Now for us, we have a particular kit. If we start looking at extractions, so this is just something that we use on a routine basis. So we use it for other periodontal surgery as well. But wherever you are in your practice, do think of creating a little kit so that things are easier for nurses, or at least a list of instruments, and keep it consistent. I think that's what's really important. So that way, everyone knows, okay, Alex is doing extractions. Okay, this is the basic setup that we need. If you have any issues with setup or questions about burrs, handpiece, shoot a question. I'd love to help. So in terms of being set up for success, so part of it is case selection, part of it is your team, understanding, your nurse, your ability for your nurse to be able to help you with suction, teaching them where to suction. Having surgical suction set up is also really critical. When I am using non-high-speed equipment, I have a surgical suction going around because often, especially when roots break, you need access. Patients, looking at the patient, what are their expectations? How nervous are they? Are there medical conditions, dental conditions? Kind of looking at everything holistically, because essentially there's a few things. There's yourself, there's the patient, there's the team, and the setup. And especially if you're doing more complex extractions, should try to be a bit more mindful of, am I set up for it? So with consent, look, extractions, I guess, are semi-elective procedures. Obviously, if there's a chronic infection in bone or acute infection in bone, elective is, I guess, a bit of a medical jargon. But you do have to kind of discuss, obviously, the risks and disclose the risks and options very kind of open up front. Today, for example, the patient referred for a 4-6 that had an apical lesion with possible root fracture. And if we looked at the CBCT scan, it was 3 millimeters away from the bone. And so we had options here. Obviously, I could refer him to an endodontist. I couldn't clinically confirm a root fracture. And I was just very open and honest in that regard. We can't clinically confirm. Look, the option is, see the root endodontist, see what they think. If they think it's an option, go through endodontic treatment. They may still diagnose a crack during that process or after that process, and we may still need to remove. If we do need to remove, medically, this patient had a history of aortic heart replacement, so we will look at some sort of antibiotic prophylaxis. But there is a risk, there's 3 millimeters away from the nerve. In the process of extraction, we have to be very careful. I consider it a low risk because the tooth is not on the nerve, but there can be bruising or swelling or damage of this nerve that can be short-term or long-term or permanent. And that's just part of the procedure and the anatomy of the situation. So make sure you have consent. Make sure you provide sufficient information, especially when risks have kind of long-term impact. If you're not aware, ADA has some guidelines on this. Let's go into case selection. So case selection is really important. It's really important that you know, okay, this is a case that I feel comfortable managing. We can go ahead, or this is a case that I think is going to be very difficult. And sometimes we get caught off guard. I'll give you, a classic example would be a erupted 3-8, so lower mandible, but the patient is maybe 40 years old. Maybe it's a male. Maybe it's a heavy set jaw. And when you take a CBCT, what you'll realize is the bone is very cortical. And so there's very little room for the bone to expand. And so a case that kind of looks initially seemingly straightforward can become very complex quickly. The other thing that you have to keep in mind is that, especially in general practice, you have a patient that is part of your general practice, right? And being able to do extraction is really important. We also want to provide a good experience, because the last thing that you want to do is take on an extraction case that doesn't go well and then potentially lose this patient as a long-term patient that could be doing restorative work, maintenance, kind of all the rest of it over the long term. So pick and also choose your patients in that regard as well. There'll be certain patients that I feel are best managed under general anesthetic. Others, I'm not sure I can provide them the best experience. And so that's how I would present the option. For others, maybe you're considering, other alternatives. So case selection, I mean, obviously this is a clear one. The risk of, what are the risks here? We've got nerve damage risks, infection risks into facial spaces. So nerve damage, jaw fracture risk is also, that's the other kind of risk that need to be mindful. If you have a patient who's a little bit more frail, just have a look. How much bone density do we have between the roots and the border of the mandible? And sometimes you might be caught off that it's actually less than what you thought. So just have a look at cases, be mindful. Surgery can be relatively high stress. So let's talk about strategies, how we can reduce that stress. What we want to do is, want to give patients a good outcome. And you also want to be time efficient. Nothing can put patients off, having an extraction booked for 30 minutes that goes for 90 minutes. So we're going to, again, talk about how we can get you the best results. And we'll go into the fun stuff a little bit in the second half. So look at the patient, understand just some basic, I'm not going to run through all of this. Understand patients that may have a high risk factor for certain complications. And, ask you, do I want to manage those complications? In terms of medical history, for example, I had a patient currently on anti-resorptive atenolol for osteoporosis. And before proceeding with extractions, for medical legal reasons, we can discuss, how do we do drug holidays? But often these medications are very individualistic. And if they're managed by a GP or endocrinologist, I will work with that medical professional to say, look, this is a procedure plan. What is your suggestive drug holiday? And I recommend that, recommend especially patients under the care of other medical practitioners with significant issues to have correspondence, both to, provide best individual care for the patient, but also to ensure that medical legally you're protected. One of the key things in your examination, limitations of opening. This is really, really important. And once again, something that can get caught off where you look, that things look pretty straightforward. Does the patient have a history of TMD? Patients that have a history of TMD, once you're doing surgical extractions or complex extractions, or honestly, any procedures where you are stretching the needle, you have a higher risk of essentially flare up after that procedure. And so you have to again, manage expectations, figure out ways, should we look at some sort of muscle relaxants, anti-inflammatories? Can we make sure that the patient rests? Can we get in and do the procedure efficiently and quickly and get out to minimize that jaw stretching? Also look at the tooth and obviously other things that may be going on. Look at your PA, look at other pathology, obviously look at your mental nerve and your sinuses. And other, sometimes, we have sometimes situations where we have accessory innervation from, for example, in the infraorbital, a canalis cynosis, which can approach the upper laterals. In the lower mandible, again, you can have accessory innervation, just being more mindful. So let's look at this. And the other thing, we talked about surgical handpiece, we talked about consent. In more complex extractions, given the reduction in radiation exposure, it is, becoming more beneficial for multiple reasons to have a CBCT. And so having that as part of your strategy and not kind of saying, look, I'll extract and this is a risk, but if it happens, we'll deal with them then. So this is a referral for a 1/6 extraction, and we're looking to do an implant here. You can see the sinus inflammation. There's an obvious OAC. So, when we're talking about risk association, looking at the scan, we actually have an erosion of bone into the sinus already. And so when we extract this tooth, we have to manage this. So part of it is going to be antibiotics and nasal decongestions prior to surgery. You may have different kind of guidelines and suggestions on how to do that. Part of it is the extraction technique to minimize any loss of further bone. When we're applying our luxators, we're mindful. We can see here. We can see the root anatomy. We can see how we should consider sectioning this tooth if we want to section this tooth. Sorry, excuse me. But also, when we go to manage this OAC, there's different approaches in terms of a buccal approach and a buccal fat pad or rotational flap approach, or using certain materials that can solidify and essentially clog the space. But having this scan gives you so much value. And so that's something I really recommend. procedures that you think are higher risk, get more information. So sectioning. When do we do it? Is it only when we do surgical? Is it, I think when we're less experienced, I think we all go through this. But if your goal is to do more surgical extractions, more complex sectioning is going to be the most critical skill that you need to build. And so I really recommend getting into that kind of straight away. I know initially we may section incorrectly, and that makes it harder because now the tooth is in section correctly. It's more difficult to remove, and hopefully we can reduce that. And we'll talk about planning, and we'll go through some cases. But starting to think about sectioning most or many of your teeth that are not single rooted and more complex. Local anesthesia. So let's go into local and let's get into the clinical side. Every patient likes local. Now, you speak to every specialist dentist, they're going to have their own flavor of how to do local, and we're going to discuss that. Part of the procedure and the local anesthetic is also, in my opinion, about patient management and providing a good patient experience. There's research to show that just having relaxing music is going to reduce stresses. Patients that can tolerate anti-inflammatories, something like 600 milligrams ibuprofen an hour before the procedure, is also going to be helpful. Patients who have dental anxiety or are concerned, having some sort of oral anxiolysis, some sort of benzodiazepine where medically safe and having someone accompany them can provide a great experience. You'll be surprised, especially when it comes to surgery, to extractions, compared to many of your other procedures, you're going to find many patients, have some level of anxiety. And look, the reality is you're taking an organ out of someone's mouth and they're not sedated. Like, it's quite a crazy concept in a way. And the fact that we don't do things with some sort of oral anxiolysis or, more with sedation is honestly atypical to the rest of medicine. Having post-op pain management and instruction is also really important about providing a great experience. But when it comes to local, a few little tips. So, when it comes to upper molars, my go-to usually will be a buccal infiltration. I'll usually have 1 or 2 carpels of Articaine, 4% with adrenaline, and also on the palatal. Again, you can see on the scan here kind of where the roots and apexes are. And so what you're looking for is, and when you're applying your infiltration, I have a 2-step process. 1, place a little bit of anesthetic into the soft tissue. 2, as that settles, then go deeper into where the apex of the root is. In the lower mandible, you can see here through the scan that sometimes what I'll do, usually if I'm extracting a single tooth, I will actually only do local infiltrations instead of doing blocks. However, you have to be a little bit strategic. So 1, buccal and lingual, but you can see here that it's fairly cortical in this area. So I'm also going to have to do intraligamentary and PDL infiltrations to provide adequate anesthesia. But if you start kind of getting more used to this technique, you can actually avoid doing blocks. Blocks I will definitely leave for cases where multiple extractions or doing perhaps other treatment at the same time, but often can get away with just local infiltrations with Articaine. So if you want to provide a bit of a gentle touch for patients, my go-to approach is in the upper. No patient likes the palatal infiltration, so providing some anesthesia around that buccal mucosa, let that settle, go deeper towards the buccal root apex. Once that kicks in, go into the buccal papilla. Once that kicks in, work your needle from buccal to palatal into that palatal papilla, let that kick in, and you'll see a bit of blanching. That's what you want to look for. And then 4, do your buccal palatal infiltration. And this is a technique so patients don't feel any of your palatal anesthetic, and a similar approach to what you do in pediatrics and kids. So step 1 in extraction, detach soft tissue. It's very common not to do this. And what can happen is that as you start doing your extraction, essentially you can have, especially where there's granulation tissue in perio kind of involved teeth, you can sometimes have some tearing of tissue. This can also lead to tuberosity fractures or other issues. So detach your tissue, use an elevator, scalpel, some sort of instrument. Step 2, this is going to be, I think, a very important part of the lecture. I'll take a little moment. Does anyone have any questions? All right, let's keep going. So when you're thinking of extractions, you have to think about space. To get a tooth out, you need space. And we have 3 ways to get space. We widen the PDL. Now, the PDL is only a fraction of a millimeter. It's not going to give you a lot. But when you are placing your luxator into that PDL, what you're actually doing is you're compressing the bone. But where will we struggle to compress bone? Where it's purely cortical bone, when there's no aeration or cancellous or vasculature in the bone. So when we look at our scans, we can kind of have a look back here, for example. We can see here on this lower mandible, that buccal plate is completely avascular or mostly avascular. So if you start putting your luxator on that buccal and putting a lot of pressure, you're not going to have compression. You're more likely to have fracture of that buccal plate. On the lingual, you can see, however, look, there actually is some vasculature and some space and marrow within that bone. And so if you place your lingual luxator lingually, you actually can get some expansion there. Tooth separation, so that's sectioning, or bone removal. Obviously, you remove your buccal plate, you move things buccally. That's the easy way and the quick way. However, it's the most destructive way and does make things more complex. Going in, like I said, think of your extractions, think of them like complex surgery, think of them like a complex restorative task. Have an assessment of the difficulty and a plan of attack. Have a look for curvatures. Have a look for roots. Have a think, why would teeth, struggle to come out? And essentially, the best way to think about this is think of an ice cream cone, or think of the easiest extractions to do. This extraction to do is your ice cream cone shaped root, right? Especially where there's vascular bone around it, because you place your luxator, you've created shape, and because it's an ice cream cone and it's widest coronally, narrowest apically, essentially as you rotate it out, the apex, as it's coming down, is going into a wider space. So if we can appreciate that that is the easiest tooth to remove, then perhaps what we need to start thinking about is, how do we change complex roots? And this is a nice example where something that looks seemingly simple on a PA, when you start looking at the scan, you start to realize, oh, there's 3 roots in this premolar. And why am I having difficulty removing this? So once we start to look at things, we can start to think about, okay, how do I create space around this root? We've got that ice cream cone shape. Let's look at the lingual and the buccal. So obviously, if you place your luxator on the buccal, you're going to get fracture of that area. So we want to preserve the buccal plate. So what's our strategy? We'll go lingually. However, we can see it's quite thick. So we have to carefully work our way lingually towards the vascular bone. But then we look at the mesiodistal bone. Quite vascular. Okay, so instead of moving things buccally, let's move things mesiodistally. Once you get some movement mesiodistally, instead of going buccal, we can start to think about rotating this tooth. And so creating that space, especially around these curved roots, you'll get this ice cream shaped space and then rotation. Now, when you start looking at scans and you're looking at all these complex root shapes, you start to realize why teeth are difficult to remove. But if we start thinking, okay, ice cream cones, easy. Most roots will have some level of complexity. Well, let's start thinking about, how do we cut these roots into an ice cream cone? And so that's kind of what you need to start thinking about. Now, this is in 2 dimensions. In 3 dimensions, we'll go into another kind of side profile view. We may need a section further. But essentially, we want to start kind of cutting these root shapes into these circular, conical, cone-shaped individual root pieces that are going to be easy to remove. And once you remove a piece of a root, you are also creating space. And as you create space, the other part of the root can move into that space. And so as you get comfortable with sectioning teeth, you're going to start to realize that the amount of force that you apply needs to be less and less in terms of relaxation. Let's look at anatomy. And this is just part of your planning as well. How deep should I be sectioning is a common question. If we look at our upper molar, typically your buccal furcation is 4 mils from the CEJ. Your mesiodistal furcations are about 3 mils or 3 to 5 mils, depending. So essentially, you want to go 4 to 5 millimeters from the CEJ. In the lower, 3 to 4 millimeters is pretty typical, but you can also assess your radiograph and assess from there. So let's go back to these cases. How do we manage this? So let's plan and assess. So we see this tooth that has a curvature. We have a look and we see, okay, look, there is this S-shaped curvature in the root. But if we look at the bone, even on a PA, we can tell that this bone is fairly vascular. And so there's going to be a couple options in terms of how we approach this. One option, we work our luxators carefully on the distal to get purchase. We'll work our luxators on the mesial. We'll get bone compression. Remember, space is the aim of the game. And if we get enough bone compression, we have to think about, where does this root want to go? Well, the top part wants to go just straight up. It's a cone shape, right? But this S-curve wants to go in that mesial direction. So if you create enough space on the mesial, work your luxator on from the distal, pushing the root mesially, you may have the root come out in one piece. But let's have a plan B. What if that doesn't happen? What if we start moving? We're just not getting that kind of budging. And you feel like, if I push any further, I'm going to have a break. Well, then let's get our burr and create this space. Again, if that isn't enough, theoretically, we don't have a tooth here, so we could create more space. But let's imagine there was a tooth next to it. Well, now what we could really do is, if we wanted to, we could section this root. And so we can section it, kind of going through essentially the coronal aspect or through the side, depending, or coming in an oblique angle. And we take away this top part, which is going to, once you section and you've had some luxation, that top part will come out straight away. And then we can create space. We can create space to bring this root in from that distal. The other way to section, to think about this is, okay, what if we section this way? If we're struggling with access, we'll take away this piece on the mesial. We can then angle in, section this top piece, and then we can bring it all out, that apical part. And you'll be able to access this distal root either through that mesial or by carefully going into that distal. And this is where the fine luxators are important. What about this lower tooth? Okay, let's have a look at the roots. Where do they want to go? Mesial wants to go up. Distal, with that curve, is going to want to move distally. So if that distal root wants to move distally and we've got contacts, that contact's going to get in the way. Let's look at the mesial root. That distal root is becoming more and more cone-shaped. Okay, so we're thinking once we can section this tooth and we get rotation, we should be able to, especially if we can move the tooth distal, be able to rotate or luxate this tooth distal. But the mesial, that's not a cone shape, right? There's two mesial canals. There is a bit of fusion towards the bottom, but it's not a typical, it's a bit of an H shape. And so what that means is bone is going to lock this in a little bit. So there's a couple ways that we could remove this. One, once the distal root is removed, we can remove the furcation bone and just luxate from the mesial and push the mesial root into the distal socket. Another option is we consider sectioning the mesial root. So we look at PA, we measure where the furcation is, Step 1, decoronate. It is very important to decoronate because as you decoronate, you actually can see by looking at the anatomy of the pulp chamber, you get an idea of the curvature. Now, how much do you want to decoronate? Usually I'd say, look, leave a few millimeters of tooth above the gum so that you have access to that. It also allows for your burrs to get into the furcation quicker. It's very hard when you haven't decoronated to accurately section the tooth. So decoronate first, section next. And now we have, I think, what did we say? Okay, well, let's try and get this distal root out, right? And if we work our luxator on the mesial of the distal root, and we try and get it out distally, hopefully it comes out. If we're struggling, now we can start to look at removing some of that furcation bone, creating a bit of space distally until we can remove that, and working like so. Let's look at some more examples. This upper molar, again, we can see the sinus and possible proximity there. We're looking, okay, let's step 1, decoronate. Step 2, start sectioning. And here I've kind of drawn a red line to show perhaps my sectioning, especially if we think about our mesial roots. Often the distal buccal root is in the midline of this, but in the mesial, you tend to want to go a little bit towards the mesiopalatal. So in this situation, we sectioned, we took each root out separately. You can see here, we preserve the furcation bone, we preserve the buccal bone, we preserve the soft tissue, put some collagen sponge in a suture here. I think the patient wants some anticoagulants perhaps, and things are pretty straightforward. What about this case? Step 1, so that's section, decoronate, section. Okay, the distal buccal root came out, the palatal root came out, but the mesiobuccal fractured. And so you might at this point feel a little bit concerned, how am I going to access? So having surgical suction is really important. And let's have a think, how are we going to get this tooth out? Well, if we can section the furcation bone between the mesiobuccal and the distal buccal root, and then we luxate from the mesial to the distal, essentially, again, we've created space. And all of something that was perhaps feeling a little bit complex, all of a sudden isn't so complex. And you can see here the furcation between the roots is broken and the tooth has been delivered. Now, it's important when I'm looking at removing bone, it's selective bone removal. Of course, we can always remove the buccal plate and completely, eliminate that and remove things that way. But when we talk about wound healing and having optimum bone healing, what we're trying to preserve is the mesial, the distal, the buccal and palatal or lingual bone. By having that four-wall bony socket, that is going to preserve our 3D dimension. If you're able to preserve furcation bone, fantastic, but it is not the most critical bone. So if we need to remove bone to make things easier, try and remove non-critical bone. I see there's a question by Dr. Vish. So when removing furcation after sectioning, do you need to scrub up and have sterile saline for irrigation? So in terms of, I guess, surgical setup, usually if I'm not raising a flap and going through a full kind of surgical extraction, I haven't got a full kind of surgical scrub setup. Obviously, we're sterile and working kind of in an aseptic environment. In terms of the burrs and the headpiece, we're doing a lot of extraction, so we have often saline set up already. But if you don't, definitely you need a surgical handpiece, and ideally, yes, you do have saline or irrigation with saline. Collagen, suture, great question though. In terms of planning, and that's Dr. Vish, that's also part of the planning. Again, if you're thinking a tooth is going to require a flap in terms of your approach, having that set up from the start makes things a lot more fast and efficient. But again, often I'm not having to raise a flap for most of my extractions that are not third molars. So let's look at this case again. Again, what are we seeing? Divergent roots, caries. So we know the crown's going to fracture. If we look at the bone, you can see some vasculature in this bone. Now, in the lower mandible, you should always assume that the buccal plate is cortical, the lingual plate is cortical. But we can see here, we've got that vasculature mesiodistally. So I'm thinking, okay, that's where I want to move my teeth and roots. Decoronate, resection. In this case, when I applied my luxators, the mesial root was more loose and mobile. Sometimes, more typically, you may have a distal, but I went for the easiest one. So we took out the mesial. You can see here there is some fracture of that furcation bone. So now let's have a think. We've got this space. Let's move the distal root into that space. Again, we apply a luxator. Instead of fracturing that plate further, we can control that fracture and remove the furcation bone in a controlled way. We've delivered the two pieces. Again, dressing, suture. So in terms of our socket management, hopefully that gives you some advice and tips in terms of how to approach sectioning. I think it's the most important thing that you can be doing. Once you've extracted the tooth, what you want to do is remove any sharp edges, either with a handpiece or some curettes that you may have. Irrigate, irrigate, irrigate. If there's any, like I said, granulation or follicle in the bone, removing that. And then just looking at the patient profile and risk. Where you have complications, you may want to look at flapping. Post-op is really critical. Essentially, I'll tell all my patients, expect that pain and swelling can peak around day 3 and 4. And to make sure that we're resting the first couple of days, essentially I say to patients, look, the more active you are, the more movement, the more blood flow, the more likely there's going to be more significant pain at a later stage. All our patients will get ice packs, gauze, instructions, including instructions on pain relief and Panadol or paracetamol ibuprofen management as the most typical management for extractions. Where you're expecting significant swelling, again, ice compression. Where there's infection risk, the need, consider antibiotics. Where you have sinuses, make sure days of decongestant. And you have sinus precaution instructions in terms of things like not using straws, not elevating that pressure in those areas. Complications. So look, the only way to avoid surgical complications is not to do any surgery. So I think we've discussed a few strategies in terms of case selection. Having CBCTs can be very helpful in more complex situations where sinus proximity, nerve proximity are to be considered. Look at yourself, the practice, your staff, your patient profile. And then again, we saw that case before with the 1/6 that had oral anatomic communication. The reality is the communication is there, or if there's a root with proximity to the nerve and you've made that assessment, it's there. We obviously don't want to make iatrogenic complications for patients, but there has to be a reality and expectation. And we need to then deem in the way I'll usually communicate to patient, look, I consider this a lower risk in your case, a moderate risk, or a high risk. And if it's a high risk, you have to really ask yourself, is it something that you want to be tackling? And are you equipped to manage the reality of the situation and the perhaps ongoing management of it? With an OAC, depending on the size, especially if it's more than 5 mils, you do have a higher risk of oral antral fistulas. And also look at the patient. Are they a heavy smoker? Do they have other kind of factors that may complicate healing? And I think in terms of communication, it's also, there are complications and there are, post-operative healing. And so things that are self-limiting is not a kind of a significant complication. But let's discuss them a little bit. So complication, you have bleeding, oral antral communication, dry socket, dislodgements of teeth, fracture, failure to complete and need to refer. So with bleeding, obviously looking at your patients, understanding do they need certain testing. For routine extraction therapy guidelines, don't suggest we need to necessarily seize any particular drugs. If we're doing more complex surgery or multiple extractions, again, speak with your medical doctor. Get them on board, both from individualistic management of the patient and also medical liability situation, timing, just being more cautious. And certain patients just need to be managed. For example, if you have a patient with hemophilia, they need to be managed in a hospital setting where they are equipped with medication and certain other things to manage these patients for extractions. Oral entry communication, determine the size. So again, hopefully this is controlled oral entry communication in the sense that you knew this was going to occur. Again, by sectioning teeth and being careful of how you apply your luxators. Remember, we don't push things into the sinus. And so again, having a CBCT or having assessment to say, okay, look, if I apply my luxators from these angles or a section in this way, I'm going to minimize that risk. But if you have significant size, understanding the management, if you can manage yourself, fantastic. If minor OACs, so less than, like I said, 5 millimeters, placing collagen dressings, suturing, considering antibiotics, nasal decongestions, sinus precautions, reviewing the patient to ensure healing. But in more significant, again, there's a lot of surgical techniques, not going to go through that in this webinar. If you're not equipped to manage, at this stage, consider making that referral to say, look, as discussed, this has happened. It's has significance. I do want to, refer you to such and such to review this and ensure that we have the best healing outcome. Dry sockets, again, self-limiting, can be very painful. We're not amazing at identifying patients that may benefit, also may be at high risk, but obviously smokers, patients with medically compromised healing, patients sometimes fiddling and doing abnormal things as well. By looking at things like local anesthetic, regranulating the area, or some sort of essentially antiseptic and pain relieving products such as alveolar gel that can be placed in the socket. But just remember, when you start placing things, okay, it does compromise the quality of the healing. There's a foreign body that needs to be worked out of it. All right, we have a question here from Jane. When you're sectioning roots, it can't clearly tell where the root ends and the bone begins, especially if it's decay, bleeding, infection, granulation tissue. How do you get a clear view? Do you just use saline and suction, or are there other techniques? That is a fantastic question, Jane. Let's go back to one of these cases. For example, here. So number one, you need surgical suction and saline as you described. Totally agree. Number two, having good light is probably number three. You need high quality light. So, if you don't have an amazing operatory light, you need a great light. I have one of the highest powered loop lights, and also magnification I find is very helpful. I've gotten to the point where I use my ergonomic 10 times loops for all my procedures, including extractions. And I find that it can be very helpful. Because if we look at this photo, if you don't have good lighting, good loops, it can be difficult. Now, to your question where it says where there is decay, bleeding, so with the bleeding, using local anesthetic, getting into, if there are vessels, occluding them with the local anesthetic, usually sufficient. If there's a lot of inflammation from granulation tissue that's adjacent, removing that. But often I will say that when you have a lot of granulation tissue, often there's bone erosion. Often the tooth is a bit easier to remove. But having said that, again, working that. Cases that, again, are a little bit tricky, having a CBCT gives you that peace of mind of knowing, okay, where is the bone? How do I kind of manage here? Where am I safe? Where am I not safe? Especially when, as you say, can be quite difficult to see. But usually, yeah, good irrigation, removal of granulation tissue, and good lining, and that is very helpful. Hopefully that helps you, Jane. If you've got another question there, please let me know. So, tooth root dislodgement, again, by having a CBCT in more complex scenarios, so when you're seeing proximity of sinus, when you're seeing lower or impacted aids that may be a little bit more difficult, having that scan gives you an idea of where are the risks of me potentially pushing into a thin area of bone. So protect those areas, use a retractor, use your finger. If you're worried about pushing a tooth into the lingual space, have literally your finger in that lingual plate to protect it. So, and if you start to feel movement of that lingual plate, you'll notice it and you can change your approach. Obviously, situation like this, please refer to your local maxillofacial surgeon. Fracture, most commonly a tuberosity fracture, but we have buccal fractures, alveolar fractures, and really the most concerning are mandibular body fractures. But look again at the age of the patient, the difficulty. Look at, again, this is where just controlling the force that is applied, the impaction depth, the pathology around it, being kind of mindful, having good access and vision, and having a gentle feel. Things happen, stay calm, keep your patient calm, explain to them the situation, get hemostasis, give them analgesia, antimicrobial mouthwashes, and call your local specialist. So we've gone through setup and the equipment. Hopefully you've taken some notes, be a bit more prepared, have a bit more equipment ready with you next time. Informed consent, make sure that you do it, just be upfront and honest. And the consent process and talking about these extractions does not have to be difficult. When I talk about, for example, I go through my implant consent process, I'll say, look, in the implant process, let's use a scenario, is we're going to be placing the implant, waiting for 3 months of integration. 3 months later, all being well, your dentist is going to restore this implant. Short-term complication, we have a failure of integration antibiotics. Failure of integration or infection. In that situation, I will need to remove the implant, let the area heal, and we'll look to revise the process. I put you in a low-risk category, so I think it'll be less than 1% chance that this will occur. Long-term complications, we can develop bone or periimplantitis infections around the implant itself if you're not keeping it clean, if you're not having regular maintenance. If there's a severe perio patient, I'll be much more strict about what those requirements are to minimize the complications, but also give them the expectations that they may need more management of that over the long term. And I say, look, if you don't look after, if you have a history of bruxism and grinding, you're going to have fractures and loosening, and we're going to have more complications, even risking implant fracture or overloading the implant and the implant fails. Now, I talk about that with all of my patients, with all the implants that are being placed. So the extraction process, the risk of nerve damage, OAC, bleeding, and in particular, that OAC risk, the need for a second procedure to close that if that's required on nerve damage is just kind of to create a spiel that feels comfortable, confident, and make that assessment of a low, medium, or high risk, and get scans and be more upfront with it. Local anesthesia, just make sure patients are very numb. Nothing will slow you down further than providing local anesthesia, starting the process, and then having to stop, provide more anesthesia. So where in doubt, patient comes in, they say, look, I've had difficulty getting numb in the past, fantastic. I'm going to give you double the local anesthetic that I would usually give from the straight up. And give them the block, even though I might usually do infiltration only. I'm going to wait 5 minutes. Again, where you can consider ibuprofen pre-op. That also helps with local anesthesia. It helps with local post-op swelling. That can be very helpful. Mechanics and anatomy. Again, I want you to start thinking about extractions like your restorative, like your endodontics, methodically planning the case. Think about bone preservation in your approach. Think about where you can create space. With surgical extractions, essentially it's just a flow-on effect. If you have more complex flapping, removing gum, removing bone, you just have to be a bit more conscious. And complication, like I said, have good assessment. So thank you everyone for your time. Hope you have a lovely evening. I'll take any questions that you may have. We've got Dr. Kank here. I'll close my presentation. I'll leave it on for now, just in case someone has something. How do you section teeth, especially where furcation starts deeper, like 5 to 6 millimeters below the CJ? So I'm just gonna have a look if I exit this slide. Can you see? No, okay. Let's bring up an example. I want to see, did any of the cases I had? So not really, but let's bring up a case that's not far off. 1 second. So I'm we're a bit stuck here. Hopefully James will join us in a moment. So sorry, I'll share my thing in a moment. But in regards to your question, what are the tips for fused roots? Okay, fused roots is a little bit different. So okay, I'll answer that question. So the question was, when you're sectioning in the furcation, so let's use this PA as example. And what you're saying is it's deeper down and there's fusion in the coronal part, and then essentially decoronation is non-negotiable. You're not going to be able to access deep enough unless you've decoronated. So make sure you decoronate first, and then make sure that you have the correct length of burrs. I think that's where a lot of people get stuck. You do need burrs that are long enough. Again, if we're thinking about the root, we're thinking about 20, 25 mils plus the 5 mils CJ. So if I have a 35 mil burr, I can pretty much get to the apex of a tooth very comfortably. And so that is going to help you ensure, so when you look at your PA, okay, this furcation's fairly deep, and then there's divergence. I need a section further down. And so just, make sure you section to that depth. This can typically be seen in upper premolars, where there can be divergence of that buccal and palatal. So definitely, if you're starting to get into kind of careful extraction techniques, minimally invasive, and you're sectioning your premolars, that's where you do need a section fairly deep, and this burr will get you there. Great question. How would you deal with a tooth that is unexpectedly ankylosed? Great question. Dr. Rose Norton. So how would you deal with a tooth that's unexpectedly ankylosed? So number one, again, this is where if you have a case with trauma scans, obviously that's going to be helpful. So number one is understanding that the tooth is actually ankylosed. So having good vision and realizing, okay, when I'm applying my luxator, I actually can't visualize, or I can't apply my luxator to actually remove this tooth. An ankylosed teeth, so sometimes we're referred cases for a anterior extraction because of history of resorption. And those are sometimes the most difficult extractions if you're just thinking of it as a tooth that's non-ankylosed. So how do I approach it? Number one, I have to make a decision. And okay, we'll take a step back. So with ankylosis, not the entire root is ankylosed often. It's partially ankylosed. So you have to decide, do I still have enough ligament where I can carefully work my way around with burrs, with luxators to try and break through the areas of ankylosis and take out the tooth. More often, the tooth is more ankylosed, and so essentially you're not going to be able to luxate this tooth out because you can't differentiate between dentine and bone. Now, let's work with the assumption that the tooth has necrosis through the pulp and an apical lesion. So now we have to ask ourselves, what is the most critical part of this tooth to remove? It's the pulp chamber. So you have to make sure that you section through and remove your pulp chamber and the entire kind of apical third, I would say, and degranulate that area. And now we kind of get into this kind of area of preservation techniques, and let's call it partial extraction techniques, where you have to ask yourself, okay, how destructive do I want to be to remove this tooth? Because essentially you have to drill out the tooth. So Rose, essentially the situation is you have to drill that whole tooth out, and that's having your hair pieces. You can get into, I guess, more nuanced side where I might say, look, actually, I don't want to drill this whole tooth out because that's going to leave a significant defect. I've removed my pulp chamber. I'm going to go a partial extraction technique where actually I'm going to leave the buccal plate intact, maybe remove the pulp chamber, the palatal aspect, Not necessarily that you have to graft that area, but that can be a more conservative approach. But really great question, very interesting. Thank you, Dr. Zainab. All right, we've got another question. Sorry that I missed that before. How do you deal with an extraction of a subcrestal oblique fracture of a tooth with a, okay, so essentially we've got a premolar, the palatal cusp has fractured and is subcrestal. So we're going to work on two assumptions. Let's go with easy assumption. It's still a conical root, or sorry, the buccal and palatal roots are fused, so not conical, but the buccal and palatal roots are fused, so single rooted. So in that situation, what am I going to do? I'm going to get fine luxators and work the mesiodistal to see how much movement I get. In terms of my setup, though, this is a more complex extraction. I have my handpiece, my burrs ready. So where in doubt, what I'm going to do, I'm going to take my root and I'm going to section it. There's two different ways you can section, kind of bucco-palatal, so through the mesiodistal, or actually through the bucco-palatal, so splitting it into a mesial half and a distal half. Both can work. One of the benefits of taking a premolar and sectioning a bucco-palatal is when you put your luxator, think of it, it's just like a lower molar. You are able to move the pieces mesiodistally as opposed to pressure on the buccal plate. But however you want to section, essentially you're going to section this piece, and you may find that what happens is the buccal half of the tooth is able to be removed, or the palatal. And this kind of goes back to the snow cone. Just you have to cut this tooth into snow cone pieces and create space. And so if you do section this tooth, and typically, you will have to section something of this situation. I had a case like this, very similar. I did a immediate extraction on an implant on a 1-4. That was a very similar situation. I wasn't able to get grip on the tooth with forceps, and I did have to section the tooth, remove it in pieces. And the moment I sectioned and created a space, the tooth came out really easily. But again, vision, access, surgical suction, all great and important. Great question, though.
I'd like to add I do a similar method as well. I'll if I have a part of a premolar that's stuck under the bone, then I will section the root in half, either mesial distal or buccal palatal. But for the premolar situation, I'd probably go for it's just me. I'll go for a mesial distal. Then, but that will give you enough room. Sorry. They'll give you enough room to collapse either the buccal or the palatal root in and get it out.
Yeah. Oh, that. I'm sure some of you have kids here as well, so thanks all for tuning in. Dr. Akan, I think we discussed this one, James. Thanks. If there's no more questions, look, it was a pleasure having this discussion, sharing. Hopefully everyone got something out of it. If you have any questions, you can reach out to me on Instagram. Very happy to connect and increase everyone's love of extractions and making it a less stressful process. So thanks, everyone.
Bye, everyone.